If we look at a historical overview of eyeglasses, it was generally believed that in the 13th century they were discovered in Italy and in China. Middle-aged monks, and this is during the time of the Gutenberg Bible, were also using spectacles. People over 40 years of age to basically see better. Myopic lenses became available later in the 15th to early 16th centuries. Bifocals can usually be attributed to Christian Hertel, who lived between 1683 and 1743. He described them, but actually Ben Franklin put them to more substantial use, and he was obviously living in between 1706 and 1790. Classically, we believe Ben Franklin to be the inventor of the bifocal. In 1801, Thomas Young was the first to describe stigmatic lenses. And in 1827, John McAllister of Philadelphia, he was the first to actually grind lenses. Isaac Hayes, not the singer, of course, between 1796 and 1879, he lived and he was in Philadelphia, and he was the first to actually prescribe them as a clinician. The demographics and epidemiology of eyeglasses are important for us to understand because 93 million Americans aged 12 years or older wear eyewear of some type to correct refractive errors. The prevalence of nearsightedness or myopia, which is greater than 0.75 diopters of myopia, it's estimated at 9% of the children in the U.S. who are ages 5 to 17 years of age. Myopia typically appears between 6 and 12 years of age. The mean rate of progression is approximately 0.5 diopters per year. Generally, we'll find that children first given glasses for the treatment of myopia, they progress the most between 8 to 13 years of age. This doesn't mean that they don't progress before that or after that, but that's the majority of the progression of myopia. Newborns average about 3 diopters of farsightedness when they're born. Hyperopia or farsightedness can increase in the first few months of life, but then it declines significantly. And it's usually an average of about 1 diopter by 1 to 2 years of age. The amplitude of accommodation, which is the ability of the child to focus away farsightedness, is approximately 14 diopters, which is plus or minus 2 diopters at the age of 8 years of age. It decreases 1 diopter every 4 years until the age of 40 years of age. At 40 years old, patient will start discovering that they had difficulty seeing it close. And this is why they then need reading glasses. Their accommodative amplitudes have decreased significantly by that time. 28% of the U.S. population aged 5 to 17 years of age have astigmatism of at least 1 diopter. And diopter, remember, is a measurement unit that we use to basically determine the strength of the lens. Different studies have shown premature infants to have a higher incidence of nearsightedness, farsightedness, and anisometropia, which is an imbalance, and astigmatism. Indication for eyeglasses in children. Children should be prescribed eyeglasses for the majority of the reasons to improve acuity. This will help them develop normally because if they can see properly, they'll develop their abilities better. And it's the same thing with actually hearing also. We also give the eyeglasses to prevent lazy eye or amblyopia. There's also situations including strabismus and refractive amblyopia, which can also be a problem. And it's also to preserve their ability to see depth perception. So we're giving children glasses not just to improve their vision, but to prevent amblyopia, to prevent strabismus, to correct imbalances, and to preserve depth perception. Other reasons why we might give glasses are to restore comfortable vision, to enhance their efficiency of their vision, to prevent progression in some cases, and to also, in these cases where a child has one good seeing eye, the protection of the non-amblyopic or lazy eye. Occasionally we even use glasses for prison therapy for turns. The different types of refractive situations why children wear glasses are bilateral nearsightedness, bilateral farsightedness. They can also have a compound type of prescription, which has a combination of astigmatism and farsightedness, or an astigmatism and nearsightedness. And there's also just plain astigmatism. Also, children are given glasses for imbalances in the prescription. One eye is more farsighted than the other, and this imbalance can create a lazy eye situation. They're also given for bilateral aphakia. Sometimes children have cataracts at birth, they have to be removed, and they have to have the lens taken out, so they're given glasses to make up for the lens that was removed. The strabismic situations where the eye turns, children are given corrections for myopic esotropia. They're given glasses for the reason of accommodative esotropia, where the eyes turn in because of farsightedness. They're given glasses for a high AC to A ratio. That's when the child's eyes converge too much when he looks close, but they don't converge that much at distance. They're usually given a bifocal for these reasons. Also, if a child has an exotropia, or an outturned eye, sometimes myopic corrections and astigmatism corrections improve the child's alignment and ability to hold their eyes together. Controversial uses for spectacles in children might be over-minusing, giving too much myopic correction to treat an outturned eye, bifocals in children who are myopic to prevent the progression of myopia, this is controversial, prism correction for strabismus, which sometimes might help double vision, and the strabismus, but might actually make the child's ability to hold his eyes together worse because he's not using the muscles because the eyes are aligned with the prism. And also for the correction of facial and ocular asymmetry. Occasionally, when a child is born with one eye smaller than the other, we might give a farsighted correction in that eye, if the eye doesn't see, to make the eye appear larger. There's also placebo use, which is controversial. Why a practitioner might not prescribe eyeglasses in children is because of low visual demands. Obviously, the younger the child is, the lower are his demands, and they might not require a small amount of prescription. Well, also, there's a likely non-compliance in a child because we have to weigh the needs versus the likelihood of amblyogenicis. So if a child has a likelihood of becoming amblyopic because of not wearing the glasses, we won't care about whether or not the child is compliant or not. We'll give the glasses. And we have to also understand that it might interrupt the child's normal development of the eye towards zero, where there's no prescription, and that's called emmetropization. Sometimes there's a feedback mechanism, and if we give too much prescription, it can actually prevent the eye from growing normally to a situation where it doesn't require glasses. And that's what we were talking about. The emmetropization is a combination of active and passive factors which cause the normal development of the visual system and growth of the eye. So we don't want to disrupt this actual growth. In making an intelligent decision on prescribing eyeglasses, then, we have to obtain a good history, perform a good cycloplegic exam, which are the dilating and cycloplegic drops that we put in the office. We want to be aware of the developmental and refractive changes that occur in a child, and know the refractive and strabismic situations which necessitate spectacles. We want to make sure that the child is not malingering, and we want to decide whether the indications for spectacles outweigh the reasons influencing you not to prescribe them. Possible scenarios in children: they don't want glasses and they don't need glasses. Well, that's good. They need glasses and want glasses. Well, that's good also. They don't need glasses, but they want glasses. Well, this is kind of indifferent. They don't need them, but they want them. That doesn't bother us. We don't necessarily want to give them. But the real problem is when you have a child who needs glasses and doesn't want glasses. These are the problems. This is a bad situation. We certainly don't want a child to not have the proper glasses so that he can maintain his normal abilities in classroom and his daily life. And we don't want him to develop a lazy eye. Why do some children avoid eyeglasses at all costs? Well, they might fear peer ridicule. There's a lot of pressure put on children in class. Obviously, bullyism today is a popular subject matter, and very often it goes unfound. So we have to make sure that the parent is aware that there could be bullyism going on, and also that the teachers and people in school who are around these children are aware that bullyism might prevent the child from wearing the appropriate correction. There's also a fear of appearing different. The child might not want to wear glasses because no one in his class had them, and he wants to, seem like all of his peers around him. Some children have personal insecurities and self-pity. They might be denial as a response to their fears. There's a lack of understanding sometimes if the parent doesn't make the child aware that glasses are not a big deal. And there might be some discomfort because of the fit of the eyeglasses, and there might be parental indifference to the child wearing them. In a book that I wrote entitled Super Sight for Seymour Bright, we pretty much approach all of these issues in a manner that a child can understand. Why write a children's book? Well, there's noncompliance, and also the child might not just be noncompliant, it might also be the parent. The book gives the clinician a tool to instruct the child and also can be used as an instructional instrument by the parent. Anyhow, Super Sight for Seymour Bright discusses a child, Seymour, whose adventure from an initial eye exam, insecurities about wearing glasses, to his eventual development of self-confidence after happily accepting his new glasses. The book explores the theme of tolerance and acceptance of individual differences in children. And Seymour basically is a young boy who was just told all of a sudden that you need glasses, and he was a fear of ridicule. So, this fear of peer ridicule and self-pity causes a problem for the child. He also says that they'll hurt my ears and mess my hair, and everyone will point and stare. So he's not just upset about fearing peer ridicule. He's also saying that the glasses will hurt him. A child will make any excuse not to wear glasses if he doesn't want to wear them. I don't like glasses, not any pair. It's just not me and just not fair. I don't like them. You would not dare. They'll pinch my nose and block the air. Denial, annoyance, insecurities. Seymour has all of these. He's also afraid of the bully. During the book, peer ridicule isn't the only issue. He actually had a child step on his glasses and break them. So obviously, Seymour is being bullied in class. So a child will emulate peers by either wanting or not wanting to wear glasses. A self-confident child, he's more likely to be unaffected by wearing eyeglasses. He'll establish a certain demeanor which the other children might actually look up to. And if he wears glasses, well, he may actually convince other children with lower self-esteem to want glasses also. I very often have children coming into the class whose friends have glasses and they pretend that they can't see. So the psychodynamics can actually not just make a child wear glasses, but not wear glasses, but make another child want to wear glasses when they don't require them. Well, this desire to emulate peers or family is very important. So if a parent wears glasses or an older brother, maybe the child will wear them also because he wants to emulate his family member or a friend. He might desire to appear more mature by wearing glasses. He might desire for attention from his parents by pretending he needs glasses. Or there's also the fashion and societal influences. Very often young girls might see glasses as an attempt to make a fashion statement. So obviously there's plenty of designer frames out there, and children very often come in very proud of their glasses because they have a designer name. The classroom dynamics dictate very often what happens with a child, and trends occur in the group based on the number of members affected. So spectacle wear, if a lot of children in the class are wearing glasses, certainly that child might be more likely to want to wear them. Insecure children will avoid ridicule of others by not wanting to wear the spectacles. Children may attempt to emulate other classmates with higher self-confidence who may or may not be wearing the spectacles. So, majority rules. Group mentality very often is the case. In these trends, self-confident children or the alpha children sometimes dominate, and bullyism might make the child decide on the improper decision in terms of glasswear. Most of the time they act on their own personal insecurities, and obviously there's fashion trends. So Seymour obviously looks through the glasses and says, wow, I can see better. So the next day when he went to class, he finished his schoolwork fast, and he was able to read, write, arithmetic, everything seemed to click. And then in the playground, he hit the ball further. So Seymour became very self-confident. And because of that, other children around him felt, well, gee, he is self-confident. Maybe I should get glasses too. Look how well Seymour's doing with them. Even the bully eventually gives in. And it obviously turned out in this case that the bully was insecure because of him for himself not being able to see. And eventually he went up to Seymour and said, hey, who's your doctor? Please tell me because I would also like to see. The bully couldn't see at distance, put the glasses on, and he could see. See, sometimes the actual bully might be acting out his own insecurities, but that's in this book. It doesn't always happen that way. So in prescribing eyeglasses in children, you have to determine the child's refractive situation by performing a good history and clinical evaluation and develop a therapeutic strategy in which will either these cases will maintain a present acuity or improve vision and alignment. You have to utilize your knowledge of children's visual development. You have to rely on the child and the child's parents to be compliant. And how do we avoid the pitfalls of noncompliance? Patient and parental education is important. We should discuss the situation in the office with the child and with the parent and give them the appropriate literature and handouts. Positive reinforcement is very important to the patient by both the clinician and the family members. And the proper follow-up examination is critical. Intervention of bullyism, if it occurs, is very important. And teachers and principals should be made aware. And, of course, you can always write a children's book. And then, you should get your eyes checked by the appropriate clinician. And then you'll also see more bright like Seymour Bright.